I'd like to welcome our very first presenter, Professor Jane Young from the Sydney School of Public Health at the University of Sydney, who will be presenting on beliefs, behaviours and systems in primary care. Please welcome Jane Young.
Thank you. Good morning, everybody. And first of all, I'd like to thank the organisers for giving me the opportunity to present on this work this morning. I think we are all in agreement that primary care is a really crucial part of the cancer system, particularly around the early diagnosis and appropriate referral of patients who present with symptoms that may be due to cancer. And this can be a particularly challenging part of a GP's role because sometimes patients present very early when it's really not clear what the final diagnosis is likely to be. Today I'm going to present some findings from a survey of GPs in New South Wales that was done as part of a larger international study run by the International Cancer Benchmarking Partnership. But I'm not going to focus on the international findings today. I'm going to focus on the findings that are particularly pertinent to New South Wales. So first of all, just a little bit of background to the ICBP, the International Cancer Benchmarking Partnership. This is an international collaboration of sort of academics, policymakers and clinicians to really look into the reasons behind what's been found to be quite marked variations in survival, in cancer survival between patients treated in different European countries. So for just the one example of rectal cancer, you can see on this slide the differences in 5-year age standardised relative survival are quite marked, from the best being in Switzerland, where 61% of patients are alive at 5 years, compared with 52% in England and 39% in Poland. And the ICBP was formed to try and answer some of these questions, and it has a particular emphasis on 3 common cancers, namely lung, colorectal and breast cancer, but also is investigating ovarian cancer as an example of a less common cancer, but also one where the pathway to diagnosis is often not straightforward. So this particular component I'm talking about today is called Module 3, and this is the component that's looking at primary care systems and how the differences in the systems perhaps could explain some of these marked variation in cancer survival between countries. So particularly in New South Wales, we wanted to also look particularly at GPs' beliefs around the diagnosis, the early diagnosis of cancer, and how they perceived their role in the cancer system. We wanted to look at their access to appropriate diagnostic tests and cancer specialists in both the public and the private sector. We wanted to look at how they said they managed patients who were presenting with symptoms that were suspicious of cancer, and their opinions about what sort of resources could help them and could help improve the interface between primary and specialist care. And particularly we were keen to look at the differences in responses between GPs working in urban areas and those in regional and rural New South Wales. So the study was an online survey. It's an international study, and you'll see the ICBP collaborators were based both in the UK, Scandinavia, several provinces in Canada, and in Australia was represented by New South Wales and Victoria. And in New South Wales and Victoria, we collaborated quite closely so that we could compare results between the two states. There was a core questionnaire for all the countries involved in this particular piece of work that looked at GPs' behaviours measured using case scenarios, and also some direct questions for the other outcomes of interest. And then we had the opportunity to add some additional questions which were identical in New South Wales and Victoria around access to services, the out-of-pocket expenses that patients might incur, what influenced GPs' referral sort of patterns and pathways, and again their preferences for the resources to help them with this work. So we identified a random sample of GPs using a commercial list given to us by AMCO because this was the most comprehensive and feasible list to use within the timelines of the study. And GPs were then stratified by their practice location into those in urban areas and those in regional and rural locations. GPs were sent a primer letter to advise them about the study before the main letter of invitation that gave them the details of how to log into the online survey. And then non-responders received up to 3 mailed reminders. And GPs were ineligible if they weren't predominantly working in clinical general practice or provided locum services only or had moved out of the area or were on leave, etc. So how did we do? Well, I think the only word that I can use to describe it is dismal in terms of the overall response rate. We started off with 2,500 names, and as is common with these commercial lists, about 10% didn't actually turn out to be eligible GPs. They didn't meet our criteria, and so invitations were sent out to the rest, which was over 2,200. We did, because we were aware that we would, that it was likely the response rate would be low. We actually embedded a randomised trial of different incentives to participation, and I'm not actually going to spend time talking about that today, but please contact me if you're interested in that. And despite all our follow-up, etc., we ended up with 273 responses, which was a 12.2% response rate. So it is what it is. Looking at who responded, we had 140 GPs from regional and rural New South Wales and 133 from major cities. A slight preponderance of men. Most GPs fell into the sort of the 45 to 65 age group. And what's interesting here is our respondents are actually quite experienced GPs. So you'll see that the majority had been in practice for 11 or more years. So we did manage to recruit experienced GPs to this study. And this is the proportion of GPs who said they agreed or strongly agreed with the importance of timely diagnosis. And you can see there was almost universal support for colorectal cancer, melanoma and breast cancer. Drops down a little bit for ovarian cancer. And then, one of the issues that David alluded to earlier this morning, the support for early diagnosis of lung cancer falls into the 80%, but the lowest was for prostate cancer, where only half of GPs felt that more timely diagnosis would improve outcomes. And this may be something to do with the use or perhaps overuse of PSA testing. So we then sought to explore GPs' views of their role in the system and the sort of the influences on them to make referrals and when they like to make referrals. So about just under 1 in 5 GPs said that they like to wait until they're absolutely sure of the diagnosis of cancer before referring to a specialist. And that was pretty similar between the urban and rural areas. The vast majority of GPs, very, very few, said they weren't clear when they should refer patients. But then there was also quite a lot of sense that GPs do feel that they have this gatekeeping role in that around 40% or slightly over in the rural areas felt that protecting patients from over-investigation was an important part of their role, and equally that preventing overload of the system in terms of overloading cancer services was an important part of their role. There's obviously a lot of influences on when and who to refer, and a considerable number of proportion of the GPs in both rural but perhaps more so in urban areas said that they felt fear of litigation was sometimes influencing their decisions to order tests and also influencing their decisions when they should refer patients. There's also a sense that sometimes GPs were, a large proportion said that they actually sometimes order investigations that they don't feel are indicated because of pressure from patients, and sometimes they referred patients on to cancer services because of patient pressure rather than because of the clinical indications. So there's obviously a complex mix of influences going on here. Then moving on to think about actual access to specialist services and specialist advice. So we asked GPs whether they were actually able to obtain advice from a cancer specialist within a couple of days to discuss appropriate investigations for somebody with suspected cancer. And there was a considerable difference between the public and the private sector, with a half able to do that in both urban and rural areas, and about 3/4 within the private system. Again, when you look at specialist referral, whether they could get a referral for a patient with suspected cancer, here we're seeing quite a large disparity between the rural public system and obviously the urban private system, so quite big differences across the system and between rural and urban areas. An area of interest that showed up between New South Wales and Victoria particularly was around direct access to colonoscopy and sigmoidoscopy for investigation of potential colorectal cancer, where you can see from these figures that this is the proportion of GPs who had access to colonoscopy and other GI tests without going through a specialist, and a considerably different proportion, much lower in New South Wales, both in rural and urban areas compared with in Victoria. But when you start looking at access to colonoscopy, so this is the proportion of GPs who reported wait, an average wait time for colonoscopy of within 4 weeks. There wasn't so much difference between New South Wales and Victoria, but there was a huge difference between the public and the private sector, which is probably not entirely unexpected. Most GPs said that they could organise colonoscopy with no out-of-pocket expenses for patients with varying degrees of difficulty. It was similar in rural and urban areas. And then looking through to, this is the proportion of GPs who reported they could actually get a patient in to see a specialist within 2 weeks across a range of specialists. And I know I've got a lot of numbers on this slide, but the key message to take home is that the access to specialists was always worse for the rural areas compared with urban areas, and lower in the public system compared with the private system. And particularly I think the one to note is for access to a gynecologic oncologist, where only 27% of GPs could organise that within 2 weeks within the public system in rural areas, so quite low. So waiting times are important. And this also came out when we asked people what actually were the main influences on choosing which specialist or which service to refer to. So you'll see the number 2 one here in both the rural areas and urban areas. About 70% of GPs nominated the length of wait for an appointment as an important factor when they're considering who they should refer their patients to. And it's also worth noting down the bottom the things that were less important, such as whether the specialist was involved in clinical trials. I mean, some of the sort of things that we might as academics think would be quite important markers of quality of care, whether the specialist is in a directory of cancer specialists, and this was particularly unimportant in the rural areas. There were some differences between rural and significant differences between rural and urban areas. So things like whether the specialist was a member of an MDT, whether they had whether the caseload of that particular specialist was important, because there's a lot of interest at the moment in volume outcome type relationships, and whether the specialist's hospital has got good published outcomes for cancer care were considered more important by urban GPs than rural GPs, but that perhaps reflects that the urban GPs have got greater choice. And then finally looking at what they felt were the most useful resources for informing them about cancer services and available referral pathways. And it's interesting that the face-to-face resources came out on top, both in the rural and urban areas. So discussions with colleagues and information that they get through GP meetings and seminars were rated most highly, as well as then feedback from patients. Written resources came in the middle, such as mailed brochures from hospitals and specialists and different GP publications, newsletters, directories, that sort of thing. And it's sort of somewhat disappointing for those of us that work at the Cancer Institute that the CanRefer website didn't rate very highly on this question, but that may be to do with sort of lack of familiarity with the resource. So obviously there are a number of limitations to this study, and we can't get away from the very low response rate. We have done some other work looking at the GP participants, and we know they do have slightly more positive attitudes towards cancer care than the non-responders, and so we need to take that into consideration as well. So these are probably the most positive results and responses, and there was some limitation in the scope of the questions due to the international requirements. So in summary, GPs generally expressed strong support for timely diagnosis to improve outcomes for breast, colorectal and melanoma skin cancer, but somewhat less for other cancer types. There was, almost half of GPs considered that gatekeeping was an important part of their role within the cancer system. Not unexpectedly, but there were marked differences still in access to diagnostic tests and specialist services between urban and regional and rural areas, and between the public and the private sector. That's going to need some thought as to how we can address that disparity. And that we found that really waiting times were one of the key drivers towards where GPs are referring their patients to. So we hope that these findings can inform future programs to improve the interface between primary and specialist care, and they also provide a baseline with which we could monitor change over time. Thank you.